Thank you, Mr. Chairman, for holding this hearing. I'd like to thank the witnesses for being here today. Biosimilars offer increased choice for patients and lower costs for the individual and healthcare system as a whole. Biosimilars are a prime example of innovation in the United States healthcare system. These drugs require a complex manufacturing process and lengthy approval process, but with nearly 70 of these products being approved by the FDA within the last decade, it just goes to show the value seen in developing these treatments. These drugs offer patients a lower cost option and create competition within the drug market. The numbers speak for themselves. Since the first biosimilar was approved in 2015, it is estimated that biosimilars have saved the U.S. healthcare system $23.6 billion and led to an average 25% decrease in biologic prices. Congress should do everything we can to support this type of innovation. Unfortunately, like too many other things, unintended consequences from lawmaking have negatively affected the biosimilar and generic market. As we've heard today, Medicare reimbursement models are hurting utilization of biosimilars, something we as Congress should examine and address. In my opinion, something that is even more harmful to the biosimilar and generic market is the IRA, the Inflation Reduction Act. We've already seen the effects of the IRA in the small molecule market with uncertainty due to price setting halting the development of new treatments. I'm extremely concerned that in the near future, biosimilars will follow suit. The IRA has weakened incentives for manufacturers to go through the arduous process of bringing a biosimilar to market. Without these incentives, patients will not have access to these lower cost drugs, and the U.S. drug market will lose the competitiveness we have been trying to promote. Mr. Burton, what impact do you expect Medicare price settings to have on future investment and development of biosimilars, and what specific barriers do you see for companies trying to bring a biosimilar to market?
Thank you for the question. You mentioned incentives. I'd say predictability. The issue is predictability. Let me put it this way. We believe biosimilars are going to generate greater savings than price negotiation. I think that's borne out if we look at what's out there today, where Stelara, through price negotiation, landed at, I believe, a 65–66% discount compared to list price. Today, there are five or six biosimilar versions of Stelara at an 80% discount, and we're all of 3 months into that market beginning. So we think biosimilars are going to deliver greater savings. The issue, though, is predictability. What kind of market are you entering? So let me put it this way. If you're thinking about a $300 million investment today that is going to, where you're going to come to market 10 years from now, you want to be able to predict what that market's going to look like. And there's a big difference if you're looking at a market that is $1 billion in annual sales versus a market that is, say, $400 million in annual sales. And because of, biosimilars are already dealing with a number of areas of uncertainty when they go into this. But the price negotiation process laid out in IRA provides zero guidance as to what that price will be. So you have to assume that a product is going to be negotiated, but you have no way of predicting what that price will be. And it's a big difference if you're, again, looking at a price cut from, say, $1 billion to $800 million or $1 billion to $400 million. That's going to affect your investment.
Thank you. A 2021 report from the National Organization of Rare Diseases found that 25% of the 552 orphan drugs and biologics on the market are approved for more than one rare disease, thanks to additional uses discovered after initial approval. Under the IRA, companies have no incentive to explore these additional uses because their risk price setting once an additional orphan designation is granted. Dr. Pat, are you concerned that this incentive could hurt progress for the 95% of rare diseases and rare cancers that are still without treatments? And then, if I could, while you're answering that, would excluding the orphan drugs from the drug pricing negotiation program, as the Orphan Cures Act does, help provide certainty in this market and create incentives for manufacturers to look for additional indications of a molecule?
I do think that there is a risk for follow-on indications when you have a drug developed. I think a great example of that is Keytruda or pembrolizumab that Dr. Murphy spoke about before. Originally, approved, I think it was in 2014 for the treatment of metastatic melanoma, subsequently kidney cancer. I think it has actually 14 different cancer indications now, and now we see, immunotherapy approved across, I think, 28 different indications. So, we all know the story of Jimmy Carter and his wonderful response to pembrolizumab, and we know that story. But I'll tell you, my own husband is a cancer survivor of 8 years of metastatic kidney cancer because of pembrolizumab, so thank God they had investments and continued approval. Again, I served as a principal investigator to bring it to breast cancer. Those additional follow-on indications become less likely if there is less incentive in the future. And so I do think that orphan drugs require special attention. I do think attention to a carve-out would provide incentives for development to continue. I worry without those incentives, it's hard for people to invest in that research and development.
Thank you, Mr. Chairman, and thank you again to the witnesses for being here.